Today we are breaking down what actually happened in Quone 2026 managed care earnings and why the recovery story that most of the financial press ran with is missing the real diagnosis. United Health, CVS, Elevance, Humana, Centene, and Molina all reported. Stocks moved up. Guidance went higher. And a lot of people concluded the medical loss ratio crisis of the past 2 years was finally over. We think that conclusion is wrong, or at minimum, it is not asking the right question. Here's the key point. Nothing in the data says care got cheaper. Hospital revenue per equivalent admission is still climbing. Senior utilization is still elevated. Specialty drug spend is still a serious cost driver. The trend on unit costs has not reversed. So why did margins improve? Because the plans stopped waiting for the trend to fix itself and started aggressively redesigning the product. There is a phrase that captures this better than anything in the sell-side notes. Benefit design recession. What that means is that payers are deliberately producing less coverage, less generosity, and less administrative looseness in order to defend their income statements. If you are a member, you feel it as higher copays, narrower formularies, tougher prior auth, fewer supplemental benefits, and fewer plan options in your county. If you are a hospital or a physician group, you feel it as more denials, more retrospective reviews, slower payment, and harder contract negotiations. Both sides take the hit, so the income statement does not. That is not a cyclical recovery. That is structural rationing in slow motion. Let us walk through 4 things the earnings actually showed. First, United Health did not say utilization was rolling over. Management explicitly flagged elevated utilization and unit cost trends and then described what they were doing to run operations harder than the trend. The language about AI investments should be read the way an operator reads it, not a venture investor. The capital is going into admin cost reduction, claims automation, and utilization management workflow, not a clinical moonshot. Second, the Molina number that almost nobody is talking about is the $93 million impairment charge tied to a planned exit from its Medicare Advantage Part D product in 2027. That is discipline in its clearest form. The company is taking a real charge today to stop bleeding tomorrow. Most observers will file that as a Molina footnote. We think it is a sector-wide signal. Not every membership is worth keeping. The cheapest claim is the one that never enters the book in the first place. Third, Humana is the cleanest read on Medicare Advantage because the company does not have much diversification cover to hide behind. The quarterly print and the full-year benefit ratio guide together are a Rorschach test. A bullish reading says Humana is still growing seniors faster than the industry. A more grounded reading says the old Medicare Advantage flywheel, where membership growth led to coding accuracy, which led to revenue, which led to stars bonuses, which led to margin, is broken at the unit level for most plans right now. The 2026 bid cycle is the first time most plans have had to design products in a world where benefit generosity and rate adequacy cannot both be true at the same time. Fourth, the Centene guidance lift on Medicaid is the most important Medicaid signal in the quarter. The post-redetermination period has been a margin nightmare because the members who stayed enrolled were sicker on average than the population that churned off. The cone read from Centene is that the acuity-to-rate gap is finally narrowing in enough states to support a more optimistic outlook. That does not mean Medicaid managed care is back to its old self, but it does mean the worst of the post-unwind shock is being absorbed. So what does all of this add up to? The benefit design recession is real. It is running across every major plan, and it is creating a very specific infrastructure buying cycle. The article goes deep on exactly what that means for builders and investors in Part 2. The thesis on where payer technology budgets are actually flowing in 2026 is specific, it is data-grounded, and it is not the narrative most people in health tech are operating on right now. Subscribe to On Healthcare for Part 2 and the full analysis, link below.